Again, this is my disclosure. 7 years old child with pain, very tight hamstrings, positive neurological finding, just about 2 weeks incontinence started, x-ray showing that's grade 3, almost 4, spondylolisthesis, and you can see the MRI and the 3D CT scan. I don't think this is the case we are going to discuss for pars repair. So when the chairman of the course asked me to discuss the pars repair for spondylolisthesis, I'm sure he did not have that in his mind. This patient, of course, had the routine expected treatment of reduction, TLIF with cages, posterior fixation. She recovered completely, she did very well, and she had a good outcome. So really, what we're going to talk about is pars repair for spondylolysis. And then we can see if we can use pars repair for spondylolisthesis very low grade. Just for the clarification, spondylolysis, as all of you, the oblique view, and you have the break in the pars, the Scotty dog view, and they call it this way because it's like a dog and a collar around the neck of the dog, and that's where you have the fracture. And that's, by the way, my dog. Literature for pars repair. There is a old literature about repairing the pars in different technique, but the modern literature came with Scott from Scotland. Reported his repair in '86. Actually, he was doing it since '70s, and he told David Bradford about it. David Bradford reported his cases in '85. Scott did it in '86, and so on. And then there are many papers showing that repair with figure-of-8 wires, as you can see here, around the transverse process to tighten the floating piece, which is the lamina and the spinous process, to the transverse process, closing the gap at the pars with bone graft, and most of the reports showing more than 90% repair of the pars and healing. I would like to say here also, 95% of the patients with spondylolysis don't need surgery, as all of you are aware, and conservative treatment, we will get relief of pain and they go back to almost all full activities. So there's a very small percentage of spondylolysis will need repair, and those using this technique. Subsequently, other technique came out. Morsher had his own design of a pedicle screw and a hook under the lamina, and now we can use this technique with any other instrument in the market. You don't have to use the specific design came by Morsher about in mid-80s. You can put pedicle screws and a bar in between going under transverse process by Gillet, and there is many other techniques. All are variation on the same theme, which is something to close the gap at the pars defect. This is the case I got from my friend Dr. Mashitko, using Morsher technique, pedicle screws, hook under the lamina. By compressing the hook against the pedicle screws, you close the gap, you put bone graft, you clean, of course, all the fibrocartilage in the pars defect, you put bone graft, and it heals fine. I got interested in that in 20 years ago or 15 years ago, where I found that Scott technique creates many times fracture of the transverse process. I gave a paper in SRS in '88 using Mersaline tape. The same idea of Scott technique, but using Mersaline tape, very flexible, pass it around the transverse process, tighten it over a decorticated bone with bone graft. That time we presented 12 cases, all of them healed without any problem. Now I have 26 cases, and it's like this case here. We have the pars defect. You can see it in the CT scan as acute. Bone scan is hot, and this is 6 months after surgery, and you can see the bridging very nicely over the pars area, and even not only that, you can see medullary canal through the pars area, reconstituting the par. We have 26 cases, and the only one case who had continuation of pain after 6 months. We did the CT scan, bone scan, and we found that the part did not heal and converted to fusion. So it works, and it's much easier technique using Mersaline tape. This is different now from using repair for spondylolisthesis. As I mentioned earlier, that's not in a condition or a procedure to discuss for high slip. It's only for slip grade 1. Literature is very scant and very little. The only paper we're mentioning the cases of spondylolisthesis specifically was Bradford paper. 2 of them who had the spondylolisthesis had failure and pseudoarthrosis. Songer paper mentioning there is there is spondylolisthesis cases but did not specify which cases. Reading the paper, 2 cases did not do very well. Most probably they are the cases of a spondylolisthesis. And it seemed like generally, if it is more than 5 millimeter spondylolisthesis with repair, they will convert into fusion. So what's the contraindication of doing a spondylolisthesis pars repair for spondylolisthesis? If you have unhealthy disc of L5S1, then is why you do repair and sooner or later the disc will deteriorate. Then might as well just do fusion. If you have a high slip angle, high pelvic incidence, If you high pelvic incidence, that means you have a very high shear forces across the pars, and the repair for a spondylolisthesis will fail. If you have a slippage more than 5 millimeter, and this from Bradford paper, and of course older patient, the 2 papers or the 3 papers available to review, the patient who did very well were in the 20s, not older than that. This is one of my patients. He has a slippage is about 10 millimeter, and we did Wilsey approach, very straightforward, 2 screws and plate with going to lateral to midline. We did not open the midline, we did not destabilize his muscles, and the patient did very well, complete relief of his symptoms. So my personal preference, probably not a repair for spondylolisthesis. Repair works very well for spondylolysis. I'm not sure works very well for spondylolisthesis. So spondylolysis repair after failure of conservative measures. Good outcome is successful in more than 90% of the cases. Spondylolisthesis grade 1 is questionable and probably much easier to do fusion and relieve the symptoms and let the guy or the patient to go back to normal activities. Thank you.
Thank you very much.